and good evening, friends. Good afternoon to our speakers, chairs, and audiences in different parts of the world. We are back again with another wonderful session of ACNS webinars. The first speaker for today is a stalwart in the field of epilepsy and functional neurosurgery, Professor Mallabhaskara Rao from India. Professor Rao is a professor of neurosurgery and also served previously as the head of department of the National Institute of Mental Health and Neurosciences, Bangalore, India. He is the president of the Indian Society of Stereotactic and Functional Neurosurgery and the Continental Vice President of the World Society of Stereotactic and Functional Neurosurgery. He is also an integral part of the Neurological Society of India and was in its executive committee till 2017. He did his fellowships from various prestigious institutions like the Mayo Clinic, the Montreal Neurological Institute, Canada, Australia, and London. He is a previous alumnus of the Sri Chitra Institute of Medical Science and Technology, Trivandrum, Kerala, where he established an outstanding epilepsy surgery program in 1995. He has also been instrumental in starting epilepsy surgery program in a number of institutions across India, Sri Lanka, and Middle East. He has trained a number of neurosurgeons in epilepsy surgery in India. Professor Rao has published several articles in various peer-reviewed international journals and has contributed to several book chapters during his academic career. We are extremely fortunate and thankful to Professor Rao for accepting our invitation to be a speaker at our webinars. The second speaker for today is a distinguished faculty from United Kingdom, Professor Richard Nelson. Professor Nelson joined the neurosurgical department in Bristol, UK in 1990 after training at the Wessex Neurological Centre in Southampton. His specialist interests include neurovascular and skull-base surgery. Until 2019, he was the chair of the Bristol Skull-Base Service and the lead vestibular schwannoma surgeon. He continues to practice as a senior honorary consultant, mentoring colleagues in complex cranial surgery. He has served as the president of the Joint Neuroscience Council, chair of the UK Neurosurgical National Audit Programme, and the president of the British Society of Neurological Surgeons. As chairman of the Specialist Advisory Committee and vice chairman of the SBNS, he was closely involved in the development of neurosurgical curriculum, neurosurgical training programs, and national selection for postgraduate neurosurgical training in the United Kingdom. We are extremely thankful to Professor Nelson for accepting our invitation to be a speaker at our webinars. A special token of thanks to Professor Ramesh Nair from the Charing Cross Hospital, London, who was our previous speaker and also integral part of the ACNS for arranging Professor Nelson as a speaker for our webinars. The chair for the first session of today is Professor Takamichi Yamamoto from Japan. Professor Yamamoto is the Executive Vice Director of the Serei Hamamatsu General Hospital, Hamamatsu, Shizuoka, Japan. He did his fellowship from the New York University Langone Medical Center, USA. He is a fellow of the American Epilepsy Society and also the member of the Epilepsy Surgery Society of Japan. He is a prominent member of the Japanese Neurosurgical Society. We are extremely thankful to Professor Yamamoto for accepting our invitation to chair the first session of today's webinar. The second chair for today's webinar is the most notable faces of Japanese neurosurgery, Professor Michiro Kono. Professor Kono is the chairman, Department of Neurosurgery, Tokyo Medical University, Tokyo, Japan. Professor Kono reserves his specialty in skull base and CP angle tumors and holds the record of the highest number of operated cases of vestibular schwannoma surgery. He is an integral part of the Japanese Neurosurgical Society and has been academically active in various online educational platforms. We are extremely thankful to Professor Kono for accepting an invitation to chair the second session of the webinars. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I hereby welcome both the chairs and speakers to this online platform of ACNS webinar. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I will hand over the virtual podium to Professor Yamamoto.
Yeah, okay. We have tonight Professor Bhaskar Rao. He's a very famous guy who is very interested in epilepsy surgery. Now he's going to talk about surgery for cortical malformations. So please start the lecture, Professor Rao.
Thanks to Raja and Professor Yamamoto for the kind introduction. Respected chairpersons and my dear participants, good evening. First of all, I am thankful to the leadership of the ACNS for this wonderful opportunity. I would also like to thank the ACNS leadership for supporting educational activities in Asia for decades. Today is World's Health Day. I take this opportunity to wish you good health and happiness. Be blessed by the divine. Be blessed by the divine. I have no financial disclosures during this presentation. I request the participants to respect the privacy of many people who underwent epilepsy surgery and being presented here with consent for educational purpose. This is my brief outline, starting with the historical note, and then I'll take you through some concepts and strategies. I'll illustrate a case of mesial temporal sclerosis to compare with the spectrum of malformations of cortical development. I'll present several illustrative cases and then end with a conclusion. Two institutions have made monumental contributions in the field of epilepsy surgery. One is the National Hospital for the Paralyzed and Epileptic at the Queen Square, London. And the second one is the Montreal Neurological Institute at Montreal, Canada. I pay tribute to the founders of Neurological Society of India who have initiated epilepsy surgery in India in the early 50s and performed sizable number of procedures both at the Christian Medical College, Vellore, as well as Madras General Hospital, Madras, by Professor Jacob Chandy, as well as Professor Balasubramaniam Ramamurthy. There was a decline in epilepsy surgery all over the world for a number of reasons. One being the advent of anti-seizure medication like carbamazepine, phenytoin, phenobarbital, sodium valproate in the 70s and 80s. There was revival of interest again later in late 80s and early 90s. NASA, along with UCLA, started developing telemetry to monitor the astronauts for the space research program, which became available for civilian use in the 80s. And then, the contributions of CT scan initially, and then magnetic resonance imaging subsequently in the evaluation of people with progressed epilepsy. It became technology intensive to initiate epilepsy surgery programs in the developing world, but I had a historic opportunity 25 years ago to start the epilepsy surgery program along with Dr. Radhakrishnan at Sri Chitra Tirunal Institute, Trivandrum, where Dr. Suresh Nair worked for a long time. Since then, there is a great progress during the past 25 years. Personally, I have performed over 1,000 epilepsy surgeries, and in India, more than 10,000 epilepsy surgery procedures were performed across 40 centers all over India. So based on the lessons learned, I will share few concepts and strategies during this webinar. I think this webinar will be good for beginners and those who just started epilepsy surgery to expand and improve their programs, and it is not prepared for the experts in epilepsy surgery. Definitions. Now, epilepsy surgery is the resection or modulation of part of the brain with the aim of alleviating seizures, improving the cognitive function and quality of life. Now, the resection is based on pathological substrate and usually cures or controls epilepsy. Where such resection is not feasible, modulation is being attempted to reduce the severity and frequency of seizures. Even though modulation is not curative, it has got an important role in the management of drug-resistant epilepsy because at present only 15 to 20% of people with drug-resistant epilepsy are suitable for resective surgery. So among the remaining, some of them have to resort to neuromodulation procedures. Now, the principle of epilepsy surgery is to identify and resect or disconnect a single epileptogenic focus and or lesion without the risk of neurological deficit. Lesion is anatomical, which we can see under microscope or you can see in the imaging, whereas focus is physiological, needs electrophysiological workup. The important point here is that lesion and focus can be together, can be adjacent, or can be far apart. Seizure cure or control will happen only when you remove both focus and lesion together. So imagine a situation where lesion and focus are far apart and the amount of pre-surgical evaluation required to decide which one has to be resected. And also either lesion or focus, if it encroaches onto the eloquent cortex, then neurological deficit is a likely likely possibility. So because of these issues, the concept of epileptogenic zone has evolved, which is defined as the area necessary and sufficient for initiating seizures and whose removal or disconnection is necessary for the abolition of seizures. Now, this is the spectrum of epilepsy surgery procedures. Of course, it has to be updated because now we have a lot of neuromodulatory procedures are incorporated. So there are procedures which will cure epilepsy, procedures which will control epilepsy, and procedures which will reduce the frequency and severity of seizures. All this depends just on two factors: where is the lesion or focus, and what is the underlying substrate. For example, you take hippocampal sclerosis or a cavernoma or a glioneuronal tumors. The identification of surgical candidacy is relatively easier with non-invasive evaluation. Surgery is standardized and outcome is good. Whereas this group, which I'm going to show you cases, the malformations of cortical development can be a bit challenging in comparison to temporal lesions. Now, there are two important principles in pre-surgical evaluation. One principle is concordance. Concordance in Latin means being of one mind. So seizures should start in one particular part of the brain. Behavior we can observe as semiology. Electrophysiology should show focus in that corresponding area. And neuroimaging should show a lesion in that area. That is the concordance, same place. Behavioral component, the semiology, the electrophysiology, as well as neuroimaging. This is concordance. Concordance means we can go ahead with the surgical strategy. Whereas if there's a discordance, it's not possible to do resective surgery. The other very important concept is redundance. Redundance is an attribute of being superfluous and unneeded. So many modalities have evolved in epilepsy surgery. So we have to tailor to the reason, location where you're practicing, and then do what is required for concordance and avoid all the redundant evaluation for these people. Now, let me give you one example of mesial temporal sclerosis so that you can compare and contrast with the malformations. This is a young girl who presented with seizures from early childhood, frequent seizures and multiple anti-seizure drugs. The careful observation of seizures will give you an idea about the origin as well as propagation. You observe the seizure here, the young girl, she's lying down, and then slowly her eyes and head deviate to the right side. There are purposeful, spontaneous movements involving the left upper limb. Look at the right upper limb, right hand fingers. There is posturing is there. It is a dystonic posturing. See the left hand is normal, whereas right hand there is a dystonic posturing. This dystonic posturing is a very robust sign of localization. This seizure has started in the left mesial temporal area and then propagated to the left basal ganglia, which causes dystonia. Now we know that by semiology, the seizure is origin is from the left mesial temporal with propagation to the left basal ganglia, which resulted in the dystonic posturing. So now you look at the EEG. EEG, this is first, it is a bipolar montage and it is color coded. See, the blue is on the left side and black is on the right side, and these are all parasagittal channels, and these are temporal channels. So she had the ictal buildup of the rhythm in the T3, T5 area, and which resulted into full-blown seizure subsequently. So there is a electroclinical concordance of mesial temporal focus. Now we'll simply look for the lesion in the MRI. See, MRI, this is right hippocampus size and shape, and compared to that left side, there's a volume reduction. You can see indirect evidence of enlargement of the temporal horn with reduction in the size of the hippocampus. And here you can see the slightly hyperintense hippocampus compared to the other side. You see this volume reduction is because of the loss of neurons, whereas hyperintense signal is because of the gliosis, and because of the volume reduction, there's indirect enlargement of the temporal horn. So, of course, she had decreased verbal memory, suggesting neurocognitive deficit. So, there is a clinical, behavioral, electrical, and imaging concordance. This is the fundamental role of pre-surgical component of the pre-surgical evaluation. Of course, she underwent resective surgery, This is left temporal horn. This is the ventricular temporal horn. This is a amygdalar nucleus. This is a nucleus surrounded by the temporal stem white matter. This the floor is by the hippocampus. Now amygdala is being resected. See, these are mesial temporal anatomy is complex but constant. Very very minor variations from person to person, unless there is some sort of developmental malformation. This is opening the choroidal fissure. And of course, subsequently, I don't want to take your time going through the entire video, but subsequently, this is the head of the hippocampus. This is the body of the hippocampus. The tail is going medially here. So this is 4 to 5 centimeter structure. Now head is being lifted. This is the cerebral peduncle. This is the one of the most important fundamental landmarks in the surgery. First is temporal horn. The second most important fundamental landmark is the hippocampal sulcus. You can see branches coming from the posterior cerebral artery supplying hippocampus. So we have to identify all the branches, coagulate, and then cut them. And subsequently, the entire hippocampus is resected en bloc. And this is the uncus being resected, and this is the end of the surgery. This is the anterocoroidal artery, cerebral peduncle, and this is the posterior cerebral artery. Now, there are two important predictive factors for this surgery. One is MRI showing complete resection of the sclerosed hippocampus. And second one is, of course, histopathology. This is the histopathology specimen of the same girl showing loss of neurons in the CA1, CA3, as well as CA4 regions. These two are very important predictive factors. MRI showing complete resection of the lesion, histopathology showing evidence of underlying pathological substrate. When we have clinical semiological, electrical, and imaging concordance, this is the outcome we get. This is based on the class 1 evidence. Unfortunately, this sort of localized anatomical, electrical, and imaging concordance, we don't get outside hippocampal pathology. You see, this is the outcomes are quite variable for other types of substrates. For example, this is the cortical dysplasia. Now, let me just say a few words regarding the cortical dysplasia. David Taylor is a psychiatrist at the Maudsley Hospital. He is the one who contributed enormously to quality of life scores among people who undergo epilepsy surgery. Along with his surgical colleague, Murray Faulkner. Faulkner is the one who gave us the question mark incision for the temporal lobectomy. So David Taylor, along with Murray Faulkner, reported about cortical dysplasia almost half a century ago. And since then, it became an area of intense and extensive research. Now, this is cortical dysplasia, focal cortical dysplasia. Focal cortical dysplasia need not be focal and need not be cortical also. abnormal critical mass of abnormal neurons anywhere in the brain can generate epileptogenic epileptic seizures. Now, the epilepsy, unlike meningiomas and gliomas, where the epilepsy is extrinsic, the surrounding neurons cause seizures in meningiomas and gliomas, whereas here the epilepsy is intrinsic. You can see here the normal cortex and white matter, whereas here that sort of cortex white matter demarcation is not there, and it is quite thick. Unlike the cortex is 4 millimeter, but here you can see a thick cortex, and then it has encroached onto the white matter. There's very poor, this is a sharp gray-white demarcation. Here there is no sharp gray-white demarcation, and which has got abnormal neurons and balloon cells. Now, in meningiomas and gliomas and even in cavernomas, when the lesion is resected, the surrounding epileptogenicity subsides in due course. So all the area which is spiking need not be removed in other lesions, in meningiomas and cavernomas and gliomas. Whereas in cortical dysplasia, everything which is spiking has to be removed to achieve seizure cure control. But the difficulty is that some of this cortex may have function also. Unlike foreign tissue lesions, these developmental malformations, developmental anomalies may have function also. See the difficulty, at one end you have to remove, you have to resect everything which is spiking. At the other end, there may be function. So these cases need can be quite challenging and may require complex and innovative pre-surgical evaluation strategies as well as surgical strategies. At NIMHANS, during the past 10 years, we have taken care of about 160 people with various types of malformations, and some of this work was published in Neurology India recently. Our outcome as well as complications are at par with the published literature. I'll take you through some illustrative cases during this presentation. For the sake of convenience as well as to show the difficulties, I have arranged these cases according to reason-wise: frontal first, temporal next, and parietal and occipital last. Now, you saw the hippocampal seizure. Look at this girl. The seizure is different. She started having the seizure during sleep. It is hypermotor. She is restless. It is pelvic thrusting.
नाम बोलो नाम बोलिए दो देख
Onset about build-up of system in the right frontal area.
नाम बोलो दो देख
And as expected, you can see poor gray-white demarcation as well as hyperintense signal in the right frontal region, being non-dominant. Generous gross total resection of the entire anatomical abnormality has been resected with no deficit and cure of her seizures. See, this boy, in contrast, had two different types of semiologies.
जीभ दिखाओ, हाथ तोलो, नाम क्या नाम है, नाम बोलो, जीभ दिखाओ.
She's stop, and this is a different type of semiology. See the intense fear in the child.
नाम बोलो, क्या नाम है बेटा, जीभ दिखाओ,
छोड़ो जीभ बेर कर
She suddenly
जीभ बेर कर
चोप बंद करो,
trigger a state.
चुप बंद करो चुप बंद करो चुप बंद करो
दान हाथ तोलो,
डानत कोई
बाण हाथ तोलो,
बामर चुप बंद करो.
The ictal easy, of course, the movement artifacts are there, but there's a buildup of rhythm in the left frontal area, and as expected, there is a lesion in the left frontal. You can see poor gray white demarcation with hyperintense signal in the left frontal area. Again, this child underwent gross total resection. You can make out from the resection cavity. This is the caudate, this is the frontal horn, this is the optic nerve. So all the way up to the base, resection extended. This is the anatomical Broca's area, and this is the motor cortex. So keeping that in margin, the resection has been planned, and then Scheser, a cure was achieved. Look at him from captivity because of the Scheser's to freedom or a period of time with resective surgery. Now this young lady had a different type of Scheser. You see, she sleeping. There's a woke up, and there is a spontaneous, purposeful movements of the left upper limb, and right upper limb is not moving. There's immobility. It's a negative motor Scheser. She is calling people with left hand because she couldn't use her right hand. And her ictal EZ showed phase reversal at F3 in the left frontal area, and she has got a large lesion corresponding to the
open your eyes,
frontal area, posterior frontal,
open your eyes, open your eyes,
with a PET showing a large area of decreased metabolism. Fiber tracking showed as if the fibers are passing through the malformation, and MEG showed a dipole cluster which is posterior to the lesion, and functional imaging showed the eloquent cortex is very close to the anatomical lesion. So to understand, to sort out functioning cortex as well as epileptogenic zone, she underwent invasive evaluation, and the ictal onset was found to be anterior part of the grid, and the stimulation of these electrodes elicited the motor function. So the motor cortex has been identified. This is the anatomical Broca's area where stimulation did not elicit any speech arrest, but it was looking as if there is a displacement of language cortex posteriorly because of the large anatomical lesion. So she underwent again gross total resection of the lesion. This is the superficial part of the lesion. This is the motor cortex. is the because we could able to identify that in the anatomical Broca's area there is no language function. So we went all the way up to the ciliary fissure and then resected that area. So that's how invasive evaluation helped us to achieve a gross total resection. And this is, you can see the extent of resection going towards the ciliary fissure and then going all the way up to the ventricle. Not all patients will have big lesions. Look at this gentleman from the early childhood who had frequent seizures and on multiple anti-epileptic medication. Look at his seizure. The bimanual posturing. Bimanual posturing.
Look here. What is your name? What is your name? Remember the color green? Remember the color green? Okay? What happened? What is this? What is this?
Clearly one can make out that's an extra hippocampal seizure, neocortical, possibly temporal, and there may be, it can be right hemispherical. And EEG showed spikes in the right anterior head region. So clinically right hemispherical seizure, EEG right frontal spike. So when we looked at imaging from the knowledge of semiology and EEG, we could able to identify this transmantle dysplasia. This is the bottom of sulcus dysplasia going all the way from sulcus up to the ventricle. And this patient underwent gross total resection of the bottom of sulcus dysplasia, and then for almost 10 years, no seizures after surgery. Now, this young lady presented with chronic epilepsy, and she actually burned her hand during one of the seizures. She subsequently developed focal status epilepticus, epileptic encephalopathy requiring prolonged ventilation. She developed septicemia and also movement disorders because of the encephalopathy and septicemia. Of course, she had a left frontal seizure is there. She was like this for several days and weeks, and she had spiking in the left central cortex, and there's only a very small tiny area, tiny area of signal, tiny area of signal alteration close to the central sulcus, and then using navigation, intra-op monitoring, and electrocorticography, the tiny area was identified and then resected. This is the depth of sulcus dysplasia. You can make out thickened cortex in the depth, discolored cortex. Now, this is the extent of resection. This is the patient after about an year from the surgery. You can see the now this child has got a sub lobar dysplasia. You can see large deep sulcus in the middle of temporal, as if she has got two temporal lobes, mesial and lateral separately. So she underwent extensive resective surgery, and then this was one of the few case reports published. Now from frontal, let us move to the temporal. You see the difference in the Caesar semiology. You can see the lips stacking. As if not able to follow the command.
नाम बताओ मंसूर नाम बताओ आगे बंद करो नाम बोलो
Now he showed a buildup of ictal rhythm in the right temporal area, and he has got a large malformation in the right temporal, and he underwent cross total resection. This is both a combination of polymicrogyric cortex as well as nodular heterotopia in the depth. You can make out the extent of the resection. Now this girl, young lady, presented with peri-Rolandic seizure.
नाम क्या है? आप नहीं, नाम बताओ आपका, नाम बताओ, आंगन करो।
It is extra hippocampal, neocortical, possibly right hemispherical. Her ictal easy showed buildup of rhythm in the right peri-Rolandic area, right central, close to central cortex, and this is the abnormality. Shared a small dysplastic lesion in the parietal area. Since her seizures has got features of Rolandic component with motor component, she underwent invasive evaluation, and then it was found that the origin actually is post central sulcus with propagation subsequently to anterior to the central sulcus. So she underwent resection of that area and then achieved seizure freedom. This girl had hemispheric right hemispheric epilepsy. You can make out there are multiple areas of dysplasia in the frontal, in the parietal, in the occipitotemporal, but she has got no focal neurological deficit, and even imaging showed that motor cortex is not involved. Even PET showed functioning of the motor cortex. So she underwent motor sparing hemispherotomy, and of course she did not achieve seizure cure, but there is a Engel class 2 outcome with significant improvement in the quality of life. Now you see this seizure, this young girl. Now she just stops and she stops breathing. See here at this stage. So several times she required ventilatory care, and my neurology colleagues opined that this could be a biomarker of SUDEP, sudden unexplained death in epilepsy. So indication for surgery became not only curing her epilepsy but also saving her life. So the only abnormality we found is that she had a small altered signal in the right occipital area with MEG dipole cluster in the occipital area. So she underwent, after informed consent, she underwent occipital lobectomy. And after lobectomy, where we thought there is a dysplasia, depth electrode and corticography showed persistent spiking. So corticectomy was extended, and even subsequently electrocorticography of the entire temporal lobe showed persistent spiking. So through the same approach through occipital horn, trigone, and temporal horn, the hippocampus was disconnected. Of course, she had type 1 dysplasia, and her seizures causing respiratory impairment stopped, but she continued to have minor seizures for several years subsequently. And this 1-year child again presented with catastrophic epilepsy, and his imaging showed left occipital altered signal in ASL imaging. And this time we wanted to make sure that the seizures are actually coming from this area. And then this child underwent invasive monitoring. And based on the ictal recordings from the occipital area, once we confirmed, we performed occipital resection again after informed consent because of the expected field effect. And for a few days, child remained without seizures, and then subsequently seizures recurred. And few weeks later, we got the genome sequence showing that child has actually got this CAN-C1H gene mutation, which is associated with idiopathic generalized epilepsy as well as childhood absence epilepsy. So these procedures in a substantial number of people will cure and control epilepsy without any risk, but there are risks associated with some people, especially for lesions which are involving eloquent cortex, and then we take utmost care to avoid and minimize these neurological deficits. Now, I will leave with few messages to the young neurosurgeons who are keen to take up epilepsy surgery, that your contribution to epilepsy surgery should not be technical. You should be part of the patient clinical evaluation every step. When a patient is referred to you for surgery, you should first check whether a patient is really has got epilepsy or not. There are anecdotal events of VNS implantation was done for people with pseudo seizures, and then you should see whether people have got who are referred for surgery, whether do they really have epilepsy? Is it focal epilepsy? Is it drug resistant epilepsy? Is it mesial temporal epilepsy or neocortical epilepsy? Is it drug resistant? Is there a lesion and a focus? Are they near together, adjacent, far apart? And what is the best optimum strategy? And what complications you can anticipate? Some of my patients before surgery, I send them to rehabilitation to prepare them for post-op rehabilitation when I expect deficits, and of course expected outcomes. So you should be familiar with all these things before you embark onto epilepsy surgery. Of course, technology is better understanding of this substrate, and then natural history and the outcome is helping us along with the technology. These are some of the recent cases done at Nimans. This is a ganglioglioma going all the way up to the ventricle, which was resected and with no deficit and seizure control. Now, a few concluding points. One is my approach as well as approach of many institutions is to expand and improve the programs in a stepwise manner. Do simple cases first and then go to complex cases next, and the evaluation, pre-surgical evaluation as well as surgical strategy. As to entire team has to evolve to take up the more complex cases. Evolution is from non-invasive to invasive, and always one has to aim to resect not only the lesion but the focus also, and every effort has to be made to avoid neurological deficits. And in case if there's a catastrophic life-threatening epilepsy, then complete cure has to be preferred in spite of having deficit which can be rehabilitated to some extent. And in at our institute as well as many other institutions in India, when people come with dual pathology, the approach is to resect both and avoiding independent evaluation, which may often require invasive and stereo easy techniques also, and use rehabilitation. And then the tissue which you resect from these people is like a gold mine for research. Preserve the tissue, and then personally, my team, and many of my colleagues in India, we demonstrate these techniques and train young neurosurgeons, and then involve in collaborative research with several other institutions within India as well as abroad. With that, I'll leave and hope that some of the young participants will take up this field and help people with progressed epilepsy. On behalf of my neurosurgery colleagues as well as entire epilepsy team, I thank you for this wonderful opportunity. Thank you very much. With that, I'll end my presentation. Thank you.
Thank you very much, Professor Rao. May I ask you a couple of questions? Thank you very much for many cases with basic knowledge and also further principles of your from your experience. And you showed large subdural grid electrodes for invasive evaluations.
Yes.
You normally use the subdural electrodes for cortical development malformations instead of a stereotactic EEG.
Yeah. The patient you're referring was operated at our institute before we initiated stereo EEG. That is one reason. Currently, we are undertaking stereo EEG evaluation, but when that case was performed, it was we were using surface grids and strips. That is one thing. Second thing, our strategy was to differentiate, separate motor cortex from the epileptogenic focus. So we thought we can get better information through that recording. Also, we wanted to cover large area, not only lesion but Broca's and central sulcus area. So and also we have in fact implanted depth electrode into parts of the lesion in that case, including into the insula, same patient. And the insular depth electrode in that same patient did not actually show any seizure origin. The origin is from the anterior superior surface part of the lesion showed, again suggesting that in a lesion, not all parts of the lesion are equally epileptogenic. There may be some parts which are highly epileptogenic, some parts which are less or non-epileptogenic at all. So one need not embark onto complete anatomical resection. So that the message we got is that the area which is closer to motor cortex was less epileptogenic. I know nowadays world is moving towards stereo EEG, and maybe in future we'll use a lot more stereo EEG rather than this grids and strips. Yeah.
Thank you. So Raja, the time is almost running out. Okay.
Right. So we'll start our next lecture. We'll invite Professor Michiro Kono.
Okay, Raja. I'm Professor Kono from Tokyo, Japan. It's my great honor to introduce Professor Richard Nelson in Bristol. Nice to see you. And he's a past president of SBNS UK. And the title of his lecture is Surgery of Vestibular Schwannoma, Lessons Learned from 30 Years. Could you start, please?
Thank you very much, Professor Kono. Let me just see if we can get a screen share working here. Colleagues, thank you very much for this invitation to join you on this training course this evening. It's mid-afternoon here in Bristol. It's rather a grey day, so we're not missing anything by being inside together. I very much enjoyed Professor Rao's lecture, and perhaps what he won't be aware of is that we do actually share a link. As you can see here, this is the National Institute in Bangalore, and here is St. John's Medical College, and St. John's Medical College is about a couple of miles to the east of the National Institute. And St. John's Medical College is where I did my first surgical house job. That was in 1978. And at the time, I was intending to be a cardiothoracic surgeon. And I spent a very enjoyable few months learning how to do pulmonary lobectomies for patients who mostly had TB. So a lot of water has passed under the bridge since then. Like Professor Rao, I would like to just give you a brief historical perspective. I think it's important. It, to some extent, informs our current practice and our approach to the management of vestibular schwannomas. And then, certainly for the benefit of the trainees, I'd like to focus most of the rest of the talk on surgical technique, and in particular on the retrosigmoid approach. And I make no apology for that. I think there are two surgical approaches which mark out a neurosurgeon and which you have to be able to do well. One, of course, is the pterional approach, as we enter the anterolateral aspect of the anterior fossa. And the other is the retrosigmoid approach, which is the single most important pivotal approach that we use in skull-based surgery, particularly in the posterior fossa. So a little bit about history. Now, I did my basic neurosurgical training back in the 1980s. And I have to say that the situation was very, very different then. One of the important factors which we tend to forget about is that we were really only just replacing CT scanning with MRI. MRI introduced clinically in 1978, 79, and in the 1980s, there were very many centers around the world with either no access to MRI scanning or very limited access. And our whole understanding of the management of vestibular schwannomas was largely based on CT scanning with contrast, occasionally with air studies. And it meant that most of the patients we were dealing with had large tumors. They were presenting with mass effect or possibly hydrocephalus. Most of them had lost any useful hearing. And we had fairly limited understanding of the natural history of vestibular schwannomas. We tended to think of them in the same light as many other intracranial tumors, benign tumors or low-grade tumors, and our perception was of a very poor natural history. At the same time, we were developing a range of really quite radical skull base approaches. And all these things came together so that we approached vestibular schwannomas as an oncological problem. Our goal was to try and achieve a total macroscopic removal. And I'm sorry to say that we wrought havoc on very large numbers of patients. The surgery was somewhat basic compared with the standards that we have today. For example, it wasn't unusual for surgeons to perform cerebellar resections to get access to these tumors. Quite a lot of surgery was being undertaken without facial nerve monitoring, which inevitably led to very high rates of facial paresis. The anesthesia, the basic surgical techniques were satisfactory, so the mortality was low, but the morbidity was high. Now, when I started my own consultant practice in 1990, things were starting to change, and I have to say they were changing for the better. The first thing that we had was a much better understanding of the natural history of vestibular schwannomas. We'd got over, by then, 10 years of monitoring data, and we realized that many vestibular schwannomas grew slowly. Some of them were indolent, didn't grow at all. So we could start to adopt a conservative management policy. Radiosurgery was becoming more accepted. I have to say there was a lot of resistance from the surgical community. But by the end of the 1980s, there was an expectation in the UK that any patient with a vestibular schwannoma was going to have at least an opinion about the possibility of having radiosurgery. And of course, our surgical approaches were improving. We were aiming for very high rates of facial nerve preservation and good facial function. And at that time, we were doing a substantial amount of work on hearing preservation. So where does that lead us to now? Well, the first thing I would say is that the conservative management of certainly small vestibular schwannomas and maybe even medium-sized VSs has to be considered a gold standard. And certainly in the UK, if you were managing a patient and you did not go into detail with them regarding the potential benefits and the place of conservative management, you would find yourself in a very difficult position if that patient decided to complain or take you to court. I think we've got a much better understanding of the impact, the symptomatic impact of hearing loss, of disequilibrium, of other symptoms, and how we should be addressing those as part of the overall management. Certainly in our unit, I would think in many other units around the world, there is a degree of equipoise in the use of microsurgery and radiosurgery. And from our point of view, that would be in tumors certainly up to 2 centimeters, possibly 2.5 centimeters, as long as there was not evidence of significant brainstem compression, and in particular, any evidence of a trigeminal neuropathy. And then if we do move to surgery, then clearly the goal of modern surgery is to minimize morbidity. We really should be aiming for anatomical facial nerve preservation in close to 100% of our patients, and good function in certainly over 90% of them. Part of my talk is also going to focus on the surgical approach and how to minimize some of the morbidity associated with the craniotomy itself. Now, as far as our surgical practice is concerned in Bristol, we will use both retrosigmoid and translabyrinthine approaches, and the choice of the approach is very much tailored to the patient, to the tumor, their hearing status, of course. It takes into account anatomical considerations. We have used middle fossa approaches in the past. We don't use them now. It is quite unusual for us to operate on a tumor, say, less than 1.5 or 2 centimeters in size, and therefore we're going to adopt either a retrosigmoid or a translabyrinthine approach. We're aiming for an optimal surgical resection. So what I mean by that is either a total macroscopic or close to total macroscopic removal. And with tumors over 2 centimeters in diameter, you are going to find that if you want to get full facial nerve preservation, in a lot of these tumors, you will need to leave capsule, which we try and minimize, particularly in the younger patients. We originally adopted that strategy, anticipating that we would have to use stereotactic radiosurgery in a significant number of patients. But I think, like many other units, what we've discovered is these capsular remnants typically don't grow, and we've demonstrated that in large prospective studies. So we will only use radiosurgery for capsular remnants that are growing, and it's a small proportion of our patients. So when do we choose the retrosigmoid approach? We're very open-minded about whether we operate retrosigmoid or translabyrinthine. There are some centres, certainly in the UK, that will almost exclusively use one route or the other, but we think there are advantages to both. Clearly, in our hands, if we're attempting hearing preservation, we will go retrosigmoid, but that's in relatively few cases these days. There's certainly a tendency, I think, to use the retrosigmoid approach for large tumours, as demonstrated here, particularly when the tumour is projecting anteriorly towards the clivus, or when the long axis of the tumour runs parallel to the posterior face of the temporal bone. Obviously, there are situations where the temporal bone anatomy is not suitable for translabyrinthine approaches, dominant sigmoid sinuses, high jugular bulbs, narrow temporal corridors, and in those cases, of course, we go retrosigmoid. And then finally, there'll be a small number of cases with recurrent tumors, and of course, if your original surgery was translabyrinthine, you will probably want to choose a retrosigmoid approach. Now, I have yet to meet a neurosurgeon who does not believe that his or her surgical technique is the best, and that anyone who adopts any different form of technique is clearly deluding themselves. But I do want to remind you that there's more than one way to skin a cat, as the old English expression goes. Or as a colleague of mine has just pointed out to me, a favorite expression of President Deng Xiaoping, who said, no matter if it's a black cat or a white cat, as long as it can catch a mouse, it's a good cat. But I will now show you how I skin a retrosigmoid cat. Whatever surgical technique you're going to use, it has to meet 5 criteria. The first thing is it must be rational. So every step of your technique has to have been worked out, and it has to make sense. There has to be a reason for doing it that way. It's clearly got to be effective. You've got to be able to deliver that technique consistently, reliably, operation after operation, year after year. And a really good technique has to be adaptable in certain circumstances. And finally, it has to meet our basic surgical principles. So if we think about the principles of surgical approaches, there are 2 elements. I mean, obviously, the surgical approach has to provide you with adequate, appropriate access. Otherwise, it's not going to be effective. And secondly, I think it needs to preserve function. And you can see there the things that we need to avoid. We need to avoid devascularizing tissues, denervating muscle, creating excessive scarring, and with some of our approaches, creating craniospinal instability. And the aim of those things, of course, is to reduce postoperative pain, maintain cosmesis, maintain function. I put this up to give you an example of an approach which I think transgresses every single one of those principles. You know, a linear incision, not dissimilar to the hockey stick incisions that we used to use, completely destructive of tissue planes, a completely non-functional approach. So if we're going to change that, we need to go back to anatomical principles. And you can see from this, this old anatomical drawing, if we're thinking about a retrosigmoid approach, we've got certain key muscle layers. We've got the sternocleidomastoid with its occipital head here. And in the layer deep to that, the single most important muscle in these approaches, which of course is the splenius muscle coming up and wrapping around the deep group of muscles. And then if we look at that from behind, again, you can see here splenius resected, and then we're into that deep layer. And again, the critical muscle here is the superior oblique muscle. And these are the anatomical layers that we're going to look for. We're going to mobilize in a functional way. So this is my technique. I refer to it as a functional retrosigmoid craniotomy. And its elements are that it's subfascial. There's a subfascial plane. We're going in intermuscular planes. We're muscle splitting in order to partially preserve muscle attachments and function. And then we're creating the free occipital bone flap. Before we actually go into the surgical approach, I just want to say something about positioning and surgical ergonomics. These are things that we tend to overlook. Positioning in neurosurgical approaches, particularly into the posterior fossa, is absolutely critical. You can turn a straightforward operation into an uphill battle by getting your positioning wrong. So I have particular views about this, which my colleagues are all aware of. So this is the retrosigmoid approach. You can do a retrosigmoid approach in a patient supine with the head rotated and the shoulder lifted. Absolutely. That's one way to skin a cat. But this is the approach that I prefer. And let me just take you through the key elements, because every one of these is important. You can see here how we've opened up I call it the cranioclydal angle. This isn't a case of just retracting the shoulder down. Remember, the shoulder articulates with the clavicle. What you're doing is you're opening up the cranioclydal angle there. We sometimes call it a park bench position, and you can see how the dependent arm there is nicely cradled over a double layer of mattress padding. And then we're in a true lateral position. We're not semi-prone. You don't go semi-prone for a retrosigmoid approach. And I like to put my support for the patient's body at the level of the pelvis, anterior and posterior support. And this is now looking at the positioning from the place where you will be standing and sitting as you operate. So some key things. First of all, put a little bit of head up on the table. Secondly, maintain the patient's craniospinal axis. By that, I mean, don't drop the head down in order to open up this angle. Maintain the craniospinal axis and then laterally flex the head on the neck at the craniocervical junction. A small amount of rotation of the head towards the floor. It's only about 15 degrees. It's bringing the face of the temporal bone towards the operating surgeon. And then finally, this concept here, which I apply in all craniotomies, it's the idea that you bring the operating field up towards the surgeon. Just as you bring the malar up as you do your pterional approach, mastoid and the occipital bone up towards you as you operate. Surgical ergonomics, and this is from the point of view of the operating surgeon. You must stand or sit with your spine in balance. If you are off balance, if you are rotated, if you are leaning across to one side, you will start to activate your core spinal muscles. And when you're doing that, you increase your motor tone, which interferes with your fine motor skills. So you have to be in balance. You have to be operating down a visual and manual axis, which is comfortable. Forearms horizontal with ulnar support. Ulnar support, absolutely essential to any neurosurgical procedure. There are all sorts of ways of achieving it. Some surgeons will have operating chairs with arm supports. Some surgeons will bring in operating handles to rest on. Others will put in things like buddy halo rings, etc., etc. What I find most convenient, in fact, is to put in an arm board which is mounted to the table. And what that means is when you change your table position, when you move from standing to sitting, when you rotate the patient, which you will do multiple times during the operation, your arm support moves with you. And it just makes it very convenient. So this is how you want to end up. There's the arm support. You can move to ulnar support at the wrist or even at the hand. The forearms are horizontal, the neck slightly flexed and relaxed, a very comfortable operating position. I could stand and operate like that for 8 hours. I tend to prefer to sit. Now, the next important thing, which people will sometimes get wrong, is mapping the incision. And what I suggest that you do as a trainee is every craniotomy you do, stop and draw it out, map it out, rehearse the surface anatomy, start to visualize the operation that you're about to do through that surface marking. There are all sorts of ways of doing it. There are all sorts of clues. The external canal is on an axial plane, is roughly in line with the internal canal. The upper edge of the internal canal will be about 6 to 7 millimeters below the tentorium. You can take the root of a zygoma across to the inion. If you look carefully, in most patients, certainly in Caucasians, there's a very subtle dip here which marks the lateral sinus. And then the critical point, of course, is the asterion, where the lateral sinus is going to turn into the sigmoid sinus and carry on down to the jugular bulb. This is where you site your craniotomy. And then in terms of the incision, there's any number of incisions you can do. Some people will do straight incisions, curvilinear incisions. If you make a shallow S incision, then any S incision in plastic surgical terms will give you greater exposure for its length. And you're aiming at 3 key points. One is the asterion. The other is the lower part of the exposure, which is going to give you access under the tumor towards the bulbar nerves. And another very important point is just here, which is the ability to retract the soft tissues back to provide you with the oblique access towards the internal auditory natus. So don't put your incision close to the sigmoid sinus because you are thinking about cerebellar retraction. Make sure you've got the soft tissue exposure. So let's now think about these tissue layers. I'm dodging between left and right exposures here. This is going to be a left exposure. And there is the, we're coming up onto the occipital bone, heading towards the parietal bone there. You can see how we've got fascial layers that have been lifted. And here we've split the sternomastoid in the line of its fibers. This muscle coming up here is the splenius muscle, the critical muscle in this exposure. This is the surgeon's view. So this is cranial, caudal. There is the sweep of the splenius fibers coming up. Here we are looking at that exposure from above, and it just shows you how you can undermine these fascial flaps in order to increase the muscle mobilization. Going back now to looking from the left side, we're now lifting the splenius off its attachment there. We're doing it at the line of the digastric groove. So we're leaving half of splenius functionally attached, and we're mobilizing this vascularized innervated flap of splenius. And this is now looking at that again from the head end. So there's the triangular splenius flap coming up. And the next deep layer there is going to be the superior oblique muscle. So we're now back to the operative position with the mastoid here. There are the fibers of the superior oblique muscle. And just as we've taken a triangular flap of splenius and we've swung it this way, we now make a flap here and we swing the superior oblique the other way. And that now brings us down onto the full exposure of the occipital bone. So I've swapped here to the right side. So we've got the mastoid here. This is cranial. This is caudal. probably the single most important part of the exposure now is the exposure of the asterion and the junction of the lateral and sigmoid sinuses. You can do burr holes here if you like. I'm not a big believer in burr holes. I think if you're going to open the cranium, then you make a targeted fine drill craniectomy. And that's what we're doing here. And this is the little curvilinear craniectomy at the top of the craniotomy, and you can see the exposed sinus. You want to expose the sinus. If you're ever operating close to a sinus, expose it. And the next step then is to cut your craniotomy. The safest way to do it is to start here and run down in the extradural plane, reaching the bottom of your craniotomy, turning very carefully at this point, and then coming back up to the craniectomy. Don't be greedy. It's often quite difficult to judge exactly where the posterior edge of the sigmoid sinus is. So yes, you could pinch a little bit more here, but if you get a dural tear into the sigmoid sinus, it's manageable in surgical terms, but it creates major difficulties for the craniotomy. So don't be too greedy. Once you've lifted your craniotomy flap, you can easily drill and undercut until you get to the back of the sigmoid sinus. The second most important part of this exposure is your CSF drainage. Now, I haven't mentioned lumbar drains because I don't use them. And we can discuss at length the pros and cons of lumbar drains. But before you go into the posterior fossa, the single most important thing you must do is drain CSF. You must never go into the posterior fossa and retract on the cerebellum when the cerebellum is tight. That is an absolute recipe for disaster. The autoregulation of the cerebellum is at best strange. And if you mishandle the cerebellum and you induce cerebellar engorgement, that is the end of your operation. And the way you avoid this is to decompress the cerebellum with careful cisternal CSF drainage. As you can see here, we're sneaking down in the subdural plane down to the basal arachnoid to open it. Size matters. When I was a trainee, Professor Mario Brock in Berlin said you can take out any size tumor from the posterior fossa by a retrosigmoid approach with a craniotomy that is 2 centimeters across. And I thought this was a little bit of Germanic hyperbole, but he was absolutely correct. So you can go into the posterior fossa with a small craniectomy using that concept of minimally invasive surgery where you have a portal through which you can approach structures at multiple angles. And there it is, and that is the final step in your retrosigmoid craniotomy, a 1.5 centimeter corridor leading you, and in the distance you can see the tumor. The reconstruction is, as you would expect, mini plates. The vascularized tissue flaps are brought back into position, sutured into position, and it provides for a very nice cosmetic functional reconstruction. So just in the last part of the talk, I want to say a little bit. I mean, we could spend a whole session talking about the surgical technique of vestibular schwannoma resection once you're in the intracranial situation. Just a few things to mention. First of all, monitoring. Clearly, facial nerve monitoring is mandatory. Brainstem auditory evoked potentials will be mandatory if you're looking at hearing preservation. Generally speaking, with certainly medium-sized tumors that are in a normal anatomical position, I haven't found any real benefit to more extensive monitoring. And I don't typically monitor the lower cranial nerves. Some of my colleagues do. I don't typically monitor the brainstem with evoked potentials, but it's certainly a reasonable thing to do, and it's a way of building up expertise in neurophysiological monitoring. The facial nerve monitoring is critical. I started my career using bipolar stimulation. I recently, or maybe in the last 5+ years, used monopolar stimulation, and there are advantages and disadvantages to both. You have to get used to the field of stimulation, whether it's monopolar or bipolar, and depending on the amplitude of your stimulation. You can see here we're using the Medtronic monitor, which I think works very, very effectively. I've never found any benefit to having more than 2 channels, although some surgeons will use 4 channels. The single most important thing is to get used to your audio signal. I virtually never look at the monitor. I don't look at the oscilloscope. I tune into the audio signal. And when you're doing that, it's very, very important that you use the same setup every time. So I will set the audio at 50%, and no one in the theatre is allowed to touch that without me asking for it to be changed. Key things in facial nerve preservation. I'm a great believer in using artificial CSF. You're working around cranial nerves, which are in a vulnerable condition. They need to be bathed with fluid that is at the right pH, has the right calcium concentration, and is at the right temperature. You can use Hartmann's. We prefer to use fully compatible artificial CSF. As I've said already, get used to using the facial nerve monitor. And as you work around the tumor, as you move to each sector of your dissection, map out your dissection plane between tumor, your arachnoid plane. Start at a high amplitude, reduce to a low amplitude until you start to get close to the facial nerve. And then I think another really, really important principle is what I call proximal and distal neural control. Now, those of you who have an interest in vascular surgery or have trained in vascular surgery will understand the principle of proximal and distal vascular control. If you're operating on an aneurysm or something of that sort. Well, the same is true of the facial nerve. And as soon as you can, get your distal neural control, and that is stimulating the facial nerve in the internal auditory meatus. Typically, that is the first point of control. And then once you can get access around the lower pole of the tumor, come down to the brainstem and get stimulation at the brainstem. And now you've got 2 points of control, and you can continue to monitor the amplitude of the signal as you dissect around the capsule. And then finally, there are 3 critical sites when dissecting a large acoustic neuroma. The first of those is actually on the lip of the porus, and it's just as the facial nerve comes out of that superior position in the porus, it's turning around the lip of the porus to start to find its way onto the convexity of the tumor. It is very easy to damage the nerve at that point. And it's almost that one overlooks the fact that the nerve is going to be very close to you at that point. The second point where the nerve is obviously vulnerable is where it is maximally displaced and splayed. And that can be in a number of positions. In the case of this tumor, it was where you might imagine it was over the deep convexity here. And then the final point where the nerve is vulnerable is at the brainstem. And I refer to something as the splay point. That is the point where, when you've identified the facial nerve at the brainstem, as it starts to move up alongside the tumor capsule, the nerve starts to splay. Once it's splayed more than twice its normal diameter at the brainstem, that is the point when you have to start looking critically at how far you can take the dissection. So we've had a good look at the retrosigmoid approach there. There are, of course, problems associated with it. The ever-present CSF fistula, we still get them. Infections are rare. Hematomas, of course, will occur in any neurosurgical approach. I think that functional craniotomy that I've demonstrated to you, certainly in our experience, has substantially reduced wound pain and some of the post-craniotomy syndromes that we used to see in the past. So thank you very much for your attention. It's been a great pleasure to join you from the other side of the world. And Professor Kono, I'd be very happy to take any questions. Thank you.
Thank you, Professor Nelson. Very educational lecture. So, is there some comments or questions?
It's a great lecture, Professor Nelson. Very educated lecture, as told by Professor Kono. Enjoyed, and I have done more than 900 vestibular schwannomas, but I learned a lot from your lecture. Thanks, Professor Nelson.
I'm not sure I can teach you very much after 900.
No. You know, every lecture we learn something. So what a nice lecture about everything. You have educated not only me, all the listeners, and this video is going to be put on website. So many students will see. You have told very correctly how to position the patient, how you should protect and safeguard all the muscles. Importantly, you told about splenius capitis, you told about superior oblique, you told about everything. And what a nice lecture, Professor. Thank you.
Thank you. Well, Cyrus, I must say that I learn something every week, and I'm very fond of saying that we are all on a learning curve. Life is a learning curve. Our surgical practice is a learning curve. And when you feel that you are no longer on an upward learning curve, that's the time to retire.
Absolutely. Absolutely, Professor. And last 1.5 years, COVID has helped us to listen to most of the lectures online free without paying any money. It was free learning for me, at least. Thank you, Thank you, Professor. Thank you.
So I know in UK, you are so have a very conservative so management for vestibular schwannomas. So you do weight and scanning and or radial surgery in most cases. So surgical cases getting smaller. But so you do the surgical policy as a planned subtotal removal and radial surgery? Do you do?
Well, yes, Professor Kono. What we try and do is to achieve the optimal surgical resection. I mean, typically that's going to be for facial nerve and obviously other cranial nerve preservation. And if you've done that, in fact, it's very rare, it's unusual that you have to use radial surgery. What we have found is that one of the determinants of whether or not a VS remnant is going to grow appears to be whether or not you've undertaken a formal dissection of the internal auditory meatus. And now that doesn't mean that you've had to resect all of the meatal tumor, but I think it's probably the action of opening the meatus, which then contributes to the devascularization of the capsular remnant. There are situations where, yes, we are going to do a subtotal removal and we will anticipate giving radiosurgery, but those are very infrequent. And in fact, the last one I can think of was operating 3 weeks ago on a patient with probably about a 22 millimeter vestibular schwannoma. The patient had intractable trigeminal neuralgia on a full dose of gabapentin, daily trigeminal neuralgia, but had perfect hearing on that side. So you've got to resect the tumor, but you're going to observe the hearing in a rather large tumor. And that means that there's going to be a reasonable amount of inferior capsule protecting the cochlear bundle. Mm. And that would be the sort of case where we would be anticipating a significant chance of having to use radiosurgery.
I agree with you. So sometimes we have to stop taking the tumor in the hypervascular tumor or those are displacement of the facial nerve. That condition makes us stop the subtotal removal.
Yes,
Thank you.
No, you're absolutely right, and as I'm sure you've experienced, Professor Kono, it's that dorsal posterior course of the facial nerve is very unusual. I have only encountered it once. My former senior colleague encountered it once, but because of that possibility, I think that's why all of us will stimulate the posterior capsule of the tumor as the first step before we do anything else. Because if you start manipulating that posterior capsule, if it's a dorsal facial nerve, it will be very thin. So in my experience of 2 cases, it's very thin. You can't see it if it's dorsal. And so you've got to pick it up with the facial nerve stimulator before you start doing something.
Yeah. Is there any questions from the
Yes, sure. There should be questions. And
Raja.
First of all, I would like to thank Professor Richard Nelson as well as Professor Bhaskar Rao for coming to the level of the students and teaching us. It was like sitting in a classroom, and both lectures were one of the best we had so far in our ACNS webinars from the point of the resident. I would like to ask Professor Nelson, what is his strategy when you have hydrocephalus along with tumor, when patients coming with small tumors and hydrocephalus?
Small tumors and hydrocephalus. So you're going to be dealing with changes in CSF viscosity, and I would opt for as near a total resection as possible. Of course, one of the other scenarios is a large tumor with hydrocephalus, and you've got various options. I mean, that might include a third ventriculostomy, some form of CSF diversion. But generally speaking, unless the patient is in extremis, I think it's in their best interest to resect the tumor and relieve the hydrocephalus by dealing with the compression of the fourth ventricle. And it seems to be that in most cases you will achieve that. Clearly, you're going to have to monitor the patient very carefully post-operatively. to make sure their hydrocephalus doesn't worsen. I suspect perhaps once a year, maybe once every year or two, we may end up in a position where we have to insert typically a ventriculoperitoneal shunt as part of the overall management of a patient with a VS. But that's pretty uncommon.
Right. So in cases where you have to put in a ventriculoperitoneal shunt, after the surgery, what would you do with that shunt? Would you remove it or would you keep it in place still?
Well, as with most shuntings, I mean, we don't routinely remove a shunt. I don't think there's any reason to do that. There's always a very small risk associated with shunt removal, as you're aware, with ventricular hemorrhage, cortical damage, even infection. So if you put a shunt in and the shunt is then redundant, as long as it's not creating any problems, we would tend to leave it in. I mean, whether that was in the context of a vestibular Schwannoma surgery or indeed any other sort of major skull-based tumor surgery.
Thank you. Thank you very much. Yes, my dear co-host Liu Boon Seng would like to comment.
Thank you, Raja. I have one question for each speaker. I'll start with Professor Nelson. I wanted to find out from Professor, say you have done a proper mapping of the facial nerve, and while removing the tumor, debarking about 70%, despite you have anatomically identified facial nerve, sometimes the stimulation may be failed in between surgery. So in that situation, what would you do? Would you trust on your monitoring, or would you still trust on your anatomically identified facial nerve? Just want to get from your advice, Professor.
Yeah. So Dr. Liu, is this a situation where you think there's a technical problem?
Yes.
With the monitoring system?
Yes, Professor.
Yeah. Well, it happens, and I regret to say that I can remember one case from about 3 or 4 years ago when there was a technical problem with a very large vestibular schwannoma in a young patient. And I had not appreciated that the facial nerve monitor was failing. And unfortunately, we lost the facial nerve. We completed the procedure and, in fact, put in a sural nerve interposition graft. Unfortunately, a couple of years down the line, the patient has pretty good facial nerve function. And that is not a situation in which you want to find yourself. So, firstly, if at all possible, you need a backup monitor. And I would say, again, once a year, I'm worried about the performance of the monitor, and we will swap out the monitor. If necessary, we will even change the facial electrodes. We will change everything with the intent of getting the facial nerve monitoring working, because I think it's so critical.
Yeah.
I actually believe that if you were partway through resection of a large VS and you had a technical failure of your monitoring, as long as the operative conditions were satisfactory, as long as you got hemostasis, I believe you would be actually justified in stopping the procedure, in staging it, and coming back when you dealt with the problem. And I have to say, if I was the patient anesthetized having that procedure, and my surgeon lost their facial nerve monitoring, that is what I would want them to do. I would prefer to have a second operation and an intact facial nerve. I mean, I wouldn't be very happy, but in extreme circumstances, that would be my preference.
Yeah, thank you, Professor. I have one more question, Raja, if you allow. I want to ask Professor Rao regarding mesial temporal sclerosis. As far as I observe, the history of febrile seizure is one of the important and always in the performer of a mesial temporal sclerosis surgery, especially epileptic temporal lobe epilepsy surgery. What importance of the information in our management of temporal lobe epilepsy, Professor? Thank you.
First of all, thank you very much for still showing your interest in epilepsy after acoustic Schwannoma surgery. I got part of the question. One is febrile seizures in mesial temporal sclerosis.
Yes.
Do you want to know, like, what is the importance of
having that part of question in our performer, whether does it help to change in our management of patient? Thank you, Professor.
I think any problem in life or neurosurgery is because of multiple factors. And this double hit hypothesis, triple hit hypothesis is a very popular concept in epilepsy. See, for example, focal cortical dysplasia we find in people without epilepsy, people with developmental anomalies, I mean, like learning disability, even normal population also, like that. So first of all, to develop mesial temporal sclerosis, there should be some sort of genetic predisposition. That is the first insult. The second insult is anything which causes early childhood insult, like meningitis, encephalitis, head injury. And in that, febrile seizures is a very important associated features. And not all. You see, if there are 100 kids with febrile seizures, 96% will not lead on to any epilepsy in later life. Only those 4 people with complicated and prolonged febrile seizures will develop epilepsy, and then some of them may develop mesial temporal sclerosis. So that's the second insult. So those with multiple insults are likely to develop mesial temporal sclerosis, which eventually requires surgical resection. Now, fortunately, all over the world, healthcare is getting better. For example, even in India, many risk factors like home deliveries, difficult like instrumented delivery, all those things are coming down significantly, even in rural India. So the number of mesial temporal sclerosis cases are coming down all over the world, including in India. Now in febrile seizures, now families having one child, two children, they're taking greater care and not to have a prolonged febrile illness, which can lead to hypoxic or ischemic brain damage. So the association is still relevant, but the incidence and prevalence of febrile seizures is coming down worldwide, and hopefully we'll see less and less in the years to come.
Thank you, Professor.
Thank you.
Thank you very much. Dr. Prajnesh Bhatt has raised his hand. Yes, Professor Prajnesh.
Dr. Raja, I just want to congratulate you, but more importantly, compliment both the speakers with whom I have some connections. Firstly, I have learned a lot from both the talks. I do not practice either of these specialties, but from Dr. Malla Rao's, Malla Bhaskar Rao's talk, I have learned a lot of fundamentals of epilepsy surgery and the science and the assessment, etc. And from Professor Nelson's, though I don't do vestibular schwannoma surgery, I have understood a lot of principles of posterior fossa, positioning, approach, and some of the finer tips that I did not know. So my heartfelt gratitude to both the speakers and more to you for organizing such a nice webinar. Thank you very much for opportunity.
Thank you, Prajnesh.
Thank you.
Thank you very much. I think if there are no further questions, we can go back to our chair, Professor Michiro Kono, to give his concluding remarks.
No other comments? No other questions?
No.
No. Okay. So now we close this session. Raja,
Yeah.
conclude
So
it.
I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to sincerely thank both the speakers for today, Professor Richard Nelson, Professor Malabhaskar Rao, and the chairs, Professor Michiro Kono and Professor Takamichi Yamamoto, for coming here and giving a beautiful teaching session to us. This, as I told you earlier, from a resident's point of view, this was one of the best webinar we had in a long time. Thank you so much. So until we meet on next Saturday, it is bye-bye from all of us. Thank you everybody for joining.